Orthopedic Centre in London, where I have the pleasure of leading several AI projects under Professor Diari Kader, and I'm undertaking a PhD in AI and orthopedics as well. So in terms of machine learning in healthcare, there's a few aspects in which, a few applications that can be used to help, used as tools to help support what we want to do and improve patient outcomes. And it'll be mostly focused on predictive analytics. And what I mean by that is using numerical data to predict patient outcomes, complications, and so on and so forth. Computer vision, using visual data, having a computer analyze visual images, and then natural language processors, having a computer understand text. But this will be focused on predictive analytics. So why machine learning? So we have traditional models, linear regression, logistic regression, they're quite common. But why do we need AI models? How would we benefit from using AI models? So first of all, AI models are very good, especially neural networks and decision trees. They're very good at interpreting the relationship between different variables. So we say that's a non-linear process, and it can understand that relationship very well, more so than the traditional models, in theory. And we know surgical risk, medical risk is not linear. So theoretically, we expect these newer AI models to work a lot better. So predictive analytics, what is that? So that's essentially using historical data to make predictions about future outcomes. And in terms of healthcare, there are three key aspects which I've noted down in which it can help. Early detection, detecting disease, detecting if a patient's going to deteriorate. Optimize resources, more so for the management side. Can we look at theatre utilization, how long a patient is going to stay in the hospital? And then decision support. Can we make the patient, the surgeon, the doctor more informed about the decisions they want to make? And just for reference for the rest of the talk, this is a performance marker we often use in machine learning. It's called AUC, area under the curve, area under the ROC curve in long. Generally, a good model is above 0.8, excellent above 0.9, and then as you get to 0.5, it's considered a failure. So bear that in mind when I talk about a few of the case studies in this presentation. So the first section, I'm going to talk about early detection and how this can be used in healthcare. So example one, disease prediction. I think the benefits are quite clear in terms of being able to predict disease. For example, we can start early intervention and identify ways to prevent disease. We can tailor treatment plans, and we can also personalize our patient surveillance. Do we need to monitor that patient once a year, every month, or however decided by the AI algorithms? And an example, a case study of this is a study which I recently read. It's a deep learning model which looks at the microbiome, so the composition of bacteria in the bowel, along with patient characteristics, their age, their ethnicity, to predict several diseases. And it was looking at predicting diabetes, cardiovascular disease, inflammatory bowel disease, cancer, autoimmune disease. The good thing about this model, it was highly interpretable. So that means that when it makes a decision, we know why it's making that decision. And we can then look at that to help optimize what we want to do and help prevent some of these diseases. The AUROC is 0.86, so quite a reasonable model here. The next example is, can we use it to identify patients who may be deteriorating on the ward? And again, the benefits are quite clear here. So timely medical intervention. If you know a patient's going to deteriorate, you can intervene earlier and aim to have better patient outcomes. And then you can also use this to help plan and allocate healthcare resources more efficiently. And a case study of this is this study which used machine learning to predict if a patient was going to develop sepsis. This was done in hospitalized patients. They trained it on 82,000 patients, which is quite a good number in terms of healthcare machine learning. And 8,000 of those were labeled as sepsis. In the UK, I'm not sure if it's like this everywhere else, but we use something called the National Early Warning Score to identify if a patient has signs of sepsis. And this model had an AUC of 0.95 compared to that, which is 0.87. So one, we know it's better than that. But number two, it also signaled sepsis 5.5 hours earlier than that model. And in terms of sepsis, that time, that 5.5 hours is extremely critical. You can give antibiotics and hopefully improve the patient outcomes with a tool like this in your system. And then the case study of this is a study which aimed to predict length of stay in patients who had a hip fracture in the UK. And they trained several machine learning models to aim to see if they could predict which patients would have an extended length of stay. trained on a low number of patients, and they used patient factors and injury variables. However, it did have a good model with an AUC of 0.98. We also know that if you have extended length of stay, you increase risk of complications. So a model like this can have several benefits, not just predicting length of stay, but predicting patient outcomes as well. And then finally, decision support. And this is one example of one of the studies we're doing. So we're looking to predict if a patient will be satisfied with a knee replacement. So we have 17,000 patients, all with 1 year follow-up data, and we have 40 variables. And the aim of this is not just to predict which patients will be satisfied with the knee replacement, but also how can we optimize that? And that leads me nicely onto personalized surgery. So the idea is a patient comes in, they come in to see someone like Professor Kader, and they have knee pain. They have all these variables, and the surgeon will put the patient details into the algorithm, and it will say you have an 82% chance of being satisfied with said surgery or knee replacement. We then ask the model, what can we do to optimize that? What variables can change? And it may suggest, well, if BMI, so the patient weight goes down to 31, that satisfaction, according to the patient's data, goes up to 93%. And this is the idea of personalized surgery, using data to drive patient care. And if you look at the natural evolution of surgery, this is how we expect it to head. In the past, historically, you would go to your surgeon, you'd have a condition or an issue, and they will suggest a procedure based on their experience and their expert opinion. At the moment, we use evidence-based medicine, so we look at literature, we have domain-based knowledge, and also patient variables, and we use that to make a prediction on what we think is the best treatment. In the future, it's data-driven care, so we utilize all the patient variables as much as we can, and we use machine learning models and algorithms to help us make these predictions. Finally, just to talk about what's the rate limiting step. So before talking about AI and all these interesting things, the most important thing is getting the data connected. Without doing that, it's very difficult to train all these AI algorithms. And I know Dr. Sercote will be probably mentioning a bit of that later. So you need to create these AI-friendly environments so then you can train these models quite quickly. And then also, I'd probably touch upon something called dynamic models, which is more of a regulatory issue. In the sense that models are tested and trained at a certain point. Data, we know, has a half-life, so data they say it's around 42 days, where the value of data halves. So ideally, if we want to use one of these models in the clinical setting, we need it to continuously learn, refine, and improve. And then also, ideally, be specific to the center. So each model will probably have to be slightly different based on the demographics or the population it's treating. So I think there will have to be an aspect of continuous learning to make it completely transferable, but more of a regulatory issue with that. Thank you for listening. I think we'll do questions at the end. Yeah, thank you.
And now I welcome Dr. Yasser on stage. I had also the pleasure to work with him before and know slightly what he's going to talk about. So he is...
I will be repeating pretty much everything that has been said.
Okay, in another way, and maybe we can, in your way, and maybe if you, since we started a little bit late, if we catch up with some time, then we can take questions from the audience. يعني إذا عندكم أسئلة بعدين تقدرون
On the intellectual copyrights of people who are developing AI, and also the proprietary rights of the companies who are providing or delivering AI in healthcare. Also, my colleagues spoke about black box phenomena. The black box, like the black box of the airplane, the black box is a characteristic of some AI algorithm where we can see the outcome, but we cannot see what is going on, how we have reached to this outcome. And the black box is opposed to they call it the glass box. So it is an opaque, complex AI, And a black box AI lacks transparency, and it hurdles the process of certification. It affects its governance, the appraisal, and it affects also the transformation of all the regulatory roles. It also affects the autonomy, and it is also, so in summation, it is less controllable or completely uncontrollable. Bias, this is a very big issue. So whatever we feed AI, garbage in, garbage out. If we feed AI poor type of data, so we are creating our bias. So bias by definition is a systematic error introduced into the algorithms, into AI, and it affects the product of the model. It has its discriminatory implications. It compromises our fairness and the fairness of AI, and it leads to erosion of trust. It makes AI inequitable. Bias, we have to mitigate them, and these are just few examples of our trials to mitigate bias in AI, but this is just a short list. It is by no means fully inclusive. We have to be robust in our data, we have to be diverse in our data set, and also the rest of this list, and the list goes on and on. Patient-related ethics. So we have the informed consent. We have to make the informed consent AI-related. We have to make the patient know about AI as much as we know about AI to deliver AI in healthcare the right way. And also the other patient-related ethic is the ethic of confidentiality. As I spoke earlier, it is an obligation on us as doctors, and it is an obligation on the AI developers and any other AI user in healthcare. So the physician-related ethics. So physicians, doctors are expected to be affected by AI. They can be over-dependent on AI. They can have de-skilling. Their skills will be lost if they overuse AI. These are all concerns. The rivalry with AI. Many people speaking about AI will take the job of the doctors in the future. So will AI be our rival in our future, in our job? Also, will we trust the machines? Will our patient trust the machines more than us, or will our patient trust us more than the machines? So, and also, can AI deliver empathy as much as we can? And are we delivering empathy to our patient the proper way so we can feed empathy into AI to use it in the future? Other shared ethics, this is a regulatory issue. This is something that have been spoken about the whole day, about who will be responsible about using, when we use AI, who will be responsible, who will be liable when something goes wrong when we use AI, whether we use AI in diagnosis or in management, whether surgical or medical or whatever. And there are suggestions. It's a very complicated issue, and there are suggestions of shared responsibility. Volumes of books can be written about the shared ethics of responsibility and liability of healthcare when we use AI in healthcare. The cost also, it will make it, will we be using AI, and will it be cost effective? Will it be affordable? Will it be transparent? And will the proprietary issues affect like the delivery of AI? It will impact our equity. I put this slide like the most advanced technologies and the most underprivileged societies in the world. Will it be equitable? And the other issue in bioethics is the regulations. Regulations have to cover every step of using AI in healthcare, in development, in deployment, in safety and efficacy, and the balance between innovation, safety, and privacy. This is a lifetime project if we work upon it. Also, the regulation standardization. We need to have our regulation, and we have to guarantee the consistency of performance. We have to create our protocols and benchmarks, whether in the government or in the private sector or in all the sectors of using AI in healthcare. Will AI be of benefit when it continuously improves, and can we maintain the quality? The collaboration. Everybody spoke about collaboration. My colleague, Dr. Sarkout, spoke about the regulations. So the most important regulations, the GDPR, which is a European regulation, it has a lot of advantages above other regulations in the world. We have also so these are the rights that are guaranteed by the GDPR. It needs a presentation alone. HIPAA, which is the Health Insurance and Portability Act, and the HIPAA privacy rule, which are applied in the USA, and also the comparison between GDPR and I don't think I have time to complete this. FDA, and how FDA is dealing with AI and how it regulates it. So the questions, the future questions about how will AI machines function ethically, learn ethically, how can we teach machines ethics, and do we have our ethical standards complete to be delivered to the machines? Solutions, like Dr. Dia spoke about earlier, we have top-down solutions starting from the level of the government, or we have bottom-up when we start to educate people and to deliver solutions. The moral calculation is a concept about using the machine to calculate the ethical product. We have a lot of controversies, whether they are binary or is it a spectrum of ethics. I know this is jargon, but yeah, it needs time to be delivered. AI in Iraq, we have to have these highlighted words. Multidisciplinary committees, international ethical guidelines should be used. We have to create our unique culturally and legally and socially fit AI. We have to collaborate with other people, and we have to keep continuing and reviewing. ChatGPT, GPT-4o. Imagine our conference like this, and this is me. I'm an eye surgeon in the NHS, and this is my LinkedIn profile. Thank you, and thank you for staying.
Thank you very much, Dr. Yasser. So I may give us not 5 minutes because we started late, so I may give us 5 minutes. Who wants to ask our speakers any questions, please? تفضلي. Your mic?
Thank you very much. I have one question or concern. Since we in healthcare, if we use AI, my question is how we can maintain or be sure that the AI remain unbiased, ethical, and transparent in decision-making process. And thank you.
Very good question. Dr. Yasser, you want to take this, or Dr. Sargal?
I need a mic. I can't shout. Yeah, so the whole issue about this is we have to ensure that we have the right data. We should start to collect the right data, and we should collect them the right way. I know the right is just, it's just a word. It encompasses everything. We should do everything the right way when we deal with our data, so AI will not deliver the garbage that we are feeding into the AI. Okay,
Yeah,
thank you.
no, that's good. Okay.